Welcome to the fourth CREOG module on caring for transgender and gender nonconforming patients for the obstetrician gynecologist. These modules were created with the support of the CREOG Empower Award and with the support of the University of Michigan. In this module, we will discuss how to address common gynecological issues among transgender and gender nonconforming patients. By the end of this module, you should be familiar with topics such as hormone therapy, menstruation, pelvic exams, reproductive counseling, family planning, breastfeeding, as well as care for transgender women who have undergone vaginoplasty. First, we will begin with hormone therapy. OBGYNs are uniquely situated to care for trans patients. Hormone therapy is a common aspect of most OBGYNs' practice and is an area of emphasis for trainees. While not all transgender or gender nonconforming people are interested in hormonal therapy as part of their transition, it is a common medical need among trans patients. Additionally, many transmasculine patients maintain their natal organs and require routine screening in accordance with the same guidelines as cisgendered women. When providing care to any trans or gender nonconforming patient, it is important to avoid assumptions about a specific transition trajectory or expectations. Hormone therapy options will need to be tailored to meet the needs and circumstances of each patient. Different surgeries may or may not be part of someone's transition. Some patients may see the transition process as a definitive period of time with specific medical and surgical components, but many people will not conceive of transition in this same way. Some patients may have surgery or hormones and not identify as transitioning. Hormone treatment is covered in a separate module. It is important, however, to know the hormonal regimen of your patient as you assess their clinical presentation. Most patients may wish to achieve amenorrhea. For those patients who are interested in testosterone therapy, achieving male range levels of serum testosterone is usually enough to suppress menses. For those who do not want to take testosterone or who want to take a dose that is too low for menstrual suppression, other methods should be explored. Depending on the medical comorbidities and preferences of the patient, continuous combined oral progesterone-only contraceptives, levonorgestrel secreting IUDs, or depomedroxyprogesterone are all reasonable treatments to consider. Some patients may have an aversion to taking estrogen-containing compounds. Others will be fine with it. Clarify the treatment goals with the patient and let them decide what is best for them. As is the case with cisgender women, irregular bleeding patterns that are not explained by medication regimen warrant further evaluation. This may include a pelvic exam, imaging, or in some cases, an endometrial biopsy. While most people will achieve amenorrhea within 1 to 6 months of initiating testosterone therapy, some will continue to have bleeding. Patients with larger adipose stores may take longer to achieve amenorrhea due to increased peripheral estrogen conversion. However, these patients are also at risk for endometrial hyperplasia and cancer, so either imaging or endometrial biopsy should be considered for persistent, irregular, or heavy bleeding. It is important to consider that for many transmasculine people, pelvic exams, imaging, and procedures may be emotionally difficult or traumatic, triggering dysphoria, or be painful due to atrophy from testosterone therapy. Please note that some transmasculine patients use their vaginas for penetrative sexual activity, while others do not. For those who do not use their vaginas for receptive penetrative activity, atrophy might impair exams. As with all patients, choosing the smallest speculum possible for adequate visualization, along with ample lubricant use, is advised. For patients on testosterone, postmenopausal patients not on any hormone therapy, or patients who do not routinely insert anything into their vaginas, a pediatric speculum might be necessary. Application of topical lidocaine prior to speculum insertion may make the exam more comfortable for the patient. Using a model of benefit maximization, consider whether the exam or test is necessary, whether there is an alternative, and how to alleviate discomfort. For example, it may be appropriate to defer all exams to an alternate date, or schedule a separate appointment for an exam after a previous appointment for discussion. It may be helpful to offer the patient to insert and control the speculum or transducer. For patients with extreme discomfort, consider offering exams or procedures under sedation if possible. It is important not to overlook routine cervical cancer and STI screening for transmasculine patients. Cervical screening should be performed in accordance with ASCCP guidelines and STI screening in accordance with CDC guidelines. There is no evidence to suggest transmasculine people are at higher risks of gynecological malignancies. They should undergo routine screening in accordance to their risk stratification. For example, presence of genetic predisposition or personal or family history of malignancy. Please see the separate preventative care module for further details. Chronic pelvic pain is a common complaint encountered in a gynecological visit. Pelvic pain in trans patients is often multifactorial, just as in cisgender patients. Additional considerations with trans patients include their hormonal regimen and surgical history. Additional assessment of pelvic pain should include the standard evaluation, assessing for urinary symptoms, pelvic infection, adnexal pathology, GI etiologies, levator myalgia, bladder tenderness, vestibulodynia, and others. For patients with levator myalgia, physical therapy is a critical component of treatment. However, it is imperative that patients be referred to trans-affirming providers for care. In addition to the nature of gynecological care, which may be inherently traumatizing for some transmasculine patients, trans patients are at an increased risk of experiencing assault and gender-related violence. For these reasons, trauma-informed care is crucial to the creation of a trans-affirming clinical practice. If atrophy is a significant cause of a patient's pain, or if atrophy is limiting a patient's desired sexual practices, they may benefit from vaginal estrogen. This is an acceptable treatment regardless of whether or not they are taking other forms of hormone therapy. While many patients on testosterone therapy may be amenorrheic, testosterone therapy cannot be considered adequate birth control. If patients engage in vaginal intercourse with partners who produce sperm and the patient is not interested in becoming pregnant, they should be counseled about birth control options. Many patients who are on testosterone therapy may not want systemic birth control methods, in which case barrier methods or IUDs may be ideal. When caring for trans patients, as with all patients, it is important not to assume what their family plans are, and to discuss the multiple existing options for parenting if they are interested. For transmasculine patients, these may include adoption, co-parenting with another parent who is a gestational parent, using the patient's own gametes to create a pregnancy carried by another person, or becoming a gestational parent, meaning carrying a pregnancy. Similar options exist for trans feminine patients, with the exception of carrying a pregnancy themselves. If patients are interested in genetically related children, if they have access to fertility care, gamete preservation is best completed prior to initiation of hormone therapy if this is acceptable for the patient. Anecdotal reports suggest that reproductive function may be preserved for at least some patients with cessation of testosterone treatment and resumption of ovulation, but larger data sets are lacking. An increasing number of transmasculine people are choosing to carry a pregnancy. This can be achieved in people who do not take testosterone, in people who plan to take testosterone but prior to initiation of treatment, or during a hiatus in testosterone treatment. However, there is insufficient data currently available regarding success rates of such pregnancies. There is no evidence that pregnancies of transgender men who have been on testosterone prior to pregnancy are higher risk pregnancies. For transgender women, exposure to estrogen can quickly decrease sperm count, but fertile semen parameters usually are achieved by 3 to 6 months after cessation of therapy. Again, there is little evidence to guide patients regarding when and to what degree sperm production will resume following cessation of hormonal treatment. Additionally, stopping hormones may not be an acceptable option for many patients, and banking gametes in advance may be preferable if this option is affordable in accordance to the patient's goals. Transmasculine and transfeminine patients may have an interest in chest or breastfeeding, and their ability to do so is largely determined by their surgical history and hormonal milieu. There are various techniques for chest masculinizing surgery. Some completely transect the milk ducts, such as free nipple grafts, and others do not. The amount of remaining breast tissue will vary on an individual basis. Additionally, pregnancy may cause changes in chest tissue growth following top surgery, which can be helpful to discuss with patients in advance. For transmasculine people who are interested in chest feeding but have had top surgery that does not allow for lactation, supplemental nursing systems are an option, depending on goals and nipple anatomy. Little is known about breastfeeding in transfeminine patients, and there are no FDA-approved regimens to elicit lactation in these circumstances. Some patients may choose to use domperidone ordered online, but this is not available in the United States. Gynecologists are well situated to provide excellent care to transfeminine patients. The gynecological needs of transfeminine patients may vary depending on their hormonal regimen and surgical history if relevant. Transfeminine patients with vaginas created by penile inversion or colovaginoplasty will have gynecological needs similar to those of cis women, with some important differences to keep in mind. HPV and cervical cancer screening is not indicated in patients with this vaginal anatomy. However, annual exams should be considered as the vaginal tissue is subject to malignancies and lesions of squamous epithelium, such as melanoma, basal cell, squamous carcinomas, condyloma, herpes, and chancroid lesions. Discharge complaints from neovaginas are often the results of retained sebum, slough tissue, or lube. Douching is recommended in the early postoperative period and may prevent troublesome discharge. The microbiome of neovaginas differs significantly from that of natal vaginas. Persistent bothersome discharge or bleeding warrants an exam. However, routine evaluations such as wet preps and vaginal pathogen probes may not be helpful. Granulation tissue may be a source of discharge and can often be treated in the office with silver nitrate. If the area is large or does not resolve with treatment, this may warrant referral back to the original surgeon if possible. A short course of metronidazole may be tried if there is no clear etiology of the discharge and it does not resolve with regular douching. Regular use of vaginal dilators may assist in achieving and maintaining a patent vagina. Gradual increases in dilator size may be helpful in addressing vaginal strictures. Fistulas are a relatively common complication of vaginoplasties and should be addressed by surgeons with experience in vaginoplasties. While androgen blockers and estrogen treatment are known to decrease sperm production, they cannot be assumed to be an adequate form of birth control for transfeminine patients. If transfeminine patients engage in sexual practices with a partner who can conceive and therefore lead to pregnancy, they should be offered contraceptive counseling. In summary, let's review the following take-home points. Transgender and gender nonconforming patients may have a range of pelvic and reproductive needs that can be addressed by a gynecologist. Persistent bleeding in a person receiving testosterone at physiologic male range levels warrants evaluation. Surgical and hormonal history should be considered when evaluating pelvic complaints. Gender-affirming hormone therapy is not adequate as birth control. And finally, counseling patients on the reproductive options is a very important component of adequate care. Thank you for viewing Module 4, which provided a basic introduction to gynecological care of transgender and gender nonconforming patients. For more information, you might consider reviewing the following sources noted in the bibliography.